Our next presenter is Kelly. She's from the Johns Hopkins School of Public Health. She's presenting results on a study that evaluated the efficacy of reactive case detection to achieve malaria elimination in rural southern Zambia using a follow-up household visits and parasite genotyping.
The green arrow goes forward.
Yeah.
Yep.
Okay, great. So thanks everybody for coming and sticking around today and listening to my talk on reactive case detection to achieve malaria elimination in southern Zambia. And so reactive test and treat, reactive case detection falls within the 5-step program that's being implemented by the National Malaria Control and Elimination Programs in Zambia to accelerate elimination. And it falls within the 4-step, step D. So sometimes I'll use these terms interchangeably. And so with step D, it is used to detect and drive out parasites from the communities using this reactive test and treat design. And how this works operationally in Zambia currently is that community health workers were trained to follow up index cases that were identified in healthcare facilities in their home, and then to test and treat all of the residents within the home, test everyone and treat those who are positive within the home, and then to travel in a counterclockwise manner out 140 meters from this index household and test all of the neighbors and treat those who are positive. And the spatial reference they were given was that this is approximate length of a soccer pitch. And while this seems operationally and simple, it's actually incredibly complex in the field. And so this began as part of the malaria elimination strategy being implemented by the government of Zambia in January of 2015. And they started in Southern Province, which has the lowest malaria transmission in the country. And there they actually had the goal to achieve elimination in the province by creating malaria-free zones at the district level. And one of the districts targeted to become one of these malaria-free zones was Choma District, which is outlined here in blue. And our study area in Macha is contained within Choma District, outlined in red. And this encompasses the catchment area of Macha Hospital. It's an area about 1,200 square kilometers, and it's a very rural area populated by traditional agrarian villagers. And we have a really pretty good idea on the malaria situation so far historically in Macha from many different perspectives. The first being from data collected by Phil Tuma on pediatric hospitalizations in Macha Hospital going back about 2 decades, where you can see a very clear trend in what happened. We see that the area had transitioned from hyperendemic to very low numbers of cases or very low numbers of pediatric hospitalizations, but we don't really actually see an elimination of the parasites yet. We still see cases each year. We also have data from surveillance at the Rural Health Center, so these are symptomatic cases that test positive by RDT. And we can see here a very seasonal pattern in malaria cases each year, but overall low numbers of cases totally, and you do see what looks like an increase in the number of cases last year, so this is 2016, and then back to a decrease in 2017. And finally, we have active case detection, where we take a random sample of the population and test them with an RDT and actually get a sample that we can test for with PCR. And from this, we can see the parasite prevalence dropped from about 9% in 2008 all the way down to less than 1% in 2013, when it became very difficult to even find cases this way. And so since they were implementing reactive case detection, or Step D, in the area, our study team transitioned to actually use this as a study design. And so we call this Enhanced Step D, and it began in March of 2015, so right at the beginning of the program as well. And how it worked is when an index case was identified in a healthcare facility, they contacted the study team, and our field team accompanied the rural health worker to the index case household. They did all of the screening and treatment there as well. And we call it enhanced because they went beyond just the 140-meter screening radius out to 250 meters, which is what's displayed on this map here. We also call it enhanced because on top of just the RDT and that screening, we collected DBS for molecular analyses, as well as a questionnaire for each individual. And then last year, we began a new, a further enhancement where we added on a longitudinal aspect to the study design, following up at day 30 and day 90 after the initial visit. And so that's what I'm going to present the results of today. But first, the first year results, we see the spatial distribution of parasite positivity by both RDT and PCR. And that's what's showing here is the index case, the prevalence and index case, and then at the different screening radius. And you can see the highest prevalence here is in the index case household. And also of note, because of the poor sensitivity of the RDT as a screening tool, we're actually capturing about twice as many cases by PCR compared to RDT. Right, and so this is showing the baseline data from when we added the longitudinal aspect. And so the table shows the characteristics of those that are PCR positive. So as you can see, the heaviest burden is within indexed households, so that's where we're finding the highest number of infections. Only about less than a fifth of them are actually RDT positive, so a good proportion are missed by the screening program. We see that these are primarily school-aged children. They have higher prevalence of fever than their negative counterparts, but overall they are primarily afebrile. And we also see that they're not traveling. So characteristically, these infections are within index households, primarily RDT negative, low parasitemic individuals who are school age and afebrile. And when we look at the parasite prevalence, which is shown here, and this is by PCR and RDT, by household type and each visit, we can see the parasite prevalence is very high by PCR for this area at the initial visit. But then we see a very nice trend, what we want to see after an intervention takes place, where we see a decrease in the parasite prevalence by the 30-day visit when we followed them up for the study visit. And we repeated those activities. So if they were RDT positive here, they were treated, and then we see another decline, but we don't see elimination of the parasite from index households. If you look at the RDT results for the same households, you would get the impression that you had achieved elimination. However, this nice pattern, we do not see it in the neighboring households at within 140 meters or 250 meters. We don't see that marked reduction in parasite prevalence by either PCR or RDT. So these patterns, we're still trying to tease apart what's going on within those households. And so we added a genetics component here. So we used the 24-SNP barcode developed by the group at Harvard to look at the relatedness of the parasites within each visit. And so the graph on the left here is just the within-visit parasite relatedness at baseline visit, and then the within visit parasite relatedness at the 30-day follow-up. And we see pretty moderate relatedness amongst these populations. But then when we look between visits, what we see is a decrease in the parasite relatedness between the 30-day visit compared to the infections at the baseline visit. So with this, we're hypothesizing that those that had higher parasitemia, the higher parasitemic infections that were positive by RDT, were potentially, those were treated at the baseline visit. And therefore, these more diverse parasites are likely representative of that asymptomatic or chronic infections in the kind of background. And we're actually able to track the transitions in positivity in individuals since we're using PCR. So within indexed households, we're actually able, these are individuals who were present and had complete data at both the baseline visit and follow-up visit that we had complete laboratory data on as well. So this is all PCR data. So of those who were positive on the first visit, we saw 4 of them actually remained positive by the second visit. So 30 days later, they still were positive by PCR. And we were able to actually see, of those negative, we saw 5 actually become PCR positive by the 30-day visit. And then within neighboring households, we see also these persistent infections where they remain positive from between the initial visit and the 30-day visit. And we're actually able to see 11 new infections or newly detected infections within this population. All right.
It's a little wonky to sit there.
Yeah. Okay.
There. Yep.
All right. And so going further with these, the genetics within these individuals. So of those that were infected and detectable by PCR in the first visit, we saw those that we had 7 persistent infections by the second visit. And we looked at the relatedness between the parasites using, again, the 24 SNP barcode, the relatedness between the infection that we detected on the 30-day visit and the infection we detected on the initial visit. And we saw that about half of the infections detected, on the 30-day follow-up visit were highly related to the infections that we detected on the initial visit. And for these, because they're not being treated, they are RDT negative, PCR positive, we actually think that these may be fluctuations in what we're detecting, the parasite clone that we're detecting at that visit type. So we're seeing fluctuations in the parasitemia and what the barcode is actually detecting at that visit type. Yeah, at that visit time, which we find to be really interesting. And then looking at within household infection persistent, we had 33 households with any infection on the first visit, and amongst those households with an infection on the first visit, we saw about a quarter of them with a newly detected infection on a subsequent visit. And so when we applied the barcode to these samples, we actually saw that about 75% were highly related to an infection that was present in the household on the first visit. So we were able to actually document this and observe within household transmission through this study design. All right, so overall, within index households, this reactive test and treat did reduce the parasite prevalence, but in neighboring households at both 140 meters and 250 meters, it did not seem to impact, or the impact is a bit less clear. However, reactive test and treat did not eliminate parasitemia nor halt transmission after these visits. And we were following up as a study activity, but the program actually only does that initial visit. So after that first visit, we saw a reduction, but not elimination of the parasite from the households. And using this study design, we're able to observe local transmission still occurring in the presence of reactive test and treat, so it's not halting transmission. And this was because we were able to do these molecular analyses and utilize the parasite genomics. And from this, it looks like that within these index households where we see the highest parasitemia and we actually see an impact of the intervention, that these likely represent transmission hotspots in the area. So where we're actually seeing the local transmission is within those index households where we're seeing higher parasitemic cases and higher burden of cases. And those infections that we're detecting in the neighboring households likely represent some sort of more of background infections, so afebrile, asymptomatic background infections that may not be substantially contributing to the ongoing and maintaining transmission in this area. And I'm fortunate enough to work on a large team and a fantastic team in the Southern and Central African isomer. And so this work was done in matcha, so I'm very grateful for our team at Matcha Research Trust, as well as all of my colleagues at the School of Public Health. And thank you.
Thank you very much, Kelly, for your very interesting and important results. We have time for only one question. Yes, please.
Hi, thanks for a really cool talk. I have a clarifying point. Could you go back to the slide where you were showing the PCR versus RDT results at follow-up and in the different neighboring villages? It was somewhere in the middle. A little bit more. Sorry. Well, while you're going through, I can ask my question, which is largely a clarifying one about the genetics.
Forward.
You missed it, but it's okay. So can you just state for me, in a couple sentences. So did you find with your genetic analysis that the villages that were experiencing a 90-day follow-up PCR positivity, but that were far away from your index cases, were those infections still genetically related to your index cases, or were you seeing quite different transmission pathways?
So with that, with the households, the sampling strategy goes from the index household out to the 250 meters, and we can look at variation in the genetics of parasites between index case responses. For this, we had actually, there are very few, you can see from this graph, PCR positive cases that were detected that would be eligible for our genomics. So with those, trying to make those comparisons, we haven't actually looked at that yet to see if we see what the relatedness between an infection in an index household is and in an infection further away or at the 90-day follow-up. So we're still looking into some of those trends.
Great. Thank you.
Yeah.